I didn't know that it'd be so hard, yeah, for me to relax, finding my purpose. I don't know what
So now let us begin with this next topic, that is preventive obstetrics. I know that using this word is not very appropriate because obstetrics in itself, it means prevention. The science which deals with prevention of any disease or pathology in a reproducing female for the child or for the mother. So of course, but for your MCQ exams, this is what it is, preventive obstetrics. We are going to talk about three topics. The ANC, that is antenatal care, ANTE. It's not ANTI, right? Antenatal care. Or we will talk about the INC, the intranatal care, or we will talk about the PNC, that is the postnatal care. See, first MCQ is this, that when we are talking about the antenatal, intranatal, or the postnatal care, why do we talk about the obstetric, that is mother, and the neonatal care together? It is very important that we always talk about the mother and child is always talked as a single unit, because the child is going to stay inside the mother for a period of 9 months. So for 9 months, the child will be with the mother. Whatever the emotional feeling, whatever the nutritional intake is there for the mother, the same is going to be affecting the child. So they both are biologically and emotionally tied together. That is the reason we take the mother and child together as a single unit, because the child is there with the mother for 9 months. So now, having understood that, let us talk about the principles of the antenatal care, that is before natality. What are the things for your exams you need to know? First MCQ is, how many visits are there in antenatal care? How many visits are there? Please note that WHO will say 8 visits. That is entirely separate. But in the government of India, we are taking that how many visits should be there? It is 4 visits. The first visit is within 12 weeks, 14 till 26 weeks, 28 till 32 weeks, and 36 weeks till term. 32 weeks till term. These are the 4 visits. The first visit, that is called as the registration visit, and subsequently you have the visit number 1, the visit 2, and the visit 3. So you can say there are 4 visits, but in technical words we call that the first visit as the registration visit, and then you have the 3 antenatal care visits, that is the 4 visits. Next point is point number 2. What are we going to do to the female during these ANC visits? First is, we are going to check the weight of the female. Please note that during the pregnancy phase, the average weight of the female should be 9 to 11 kgs gain in the weight during her pregnancy. During the entire pregnancy, the total weight gain excess should be 9 to 11 kgs. Less than 9, it is a problem. More than 11, it will be a problem. So the ideal weight gain during pregnancy, it is usually 10 kgs, we say, is the ideal weight gain. But of course, it can be, the range would be from 9 to 11 kgs. Also, talking still more about weight, the female should have an increase in weight at the rate of at least 2 kilograms per month, not more than that. Not more than 2 kilograms per month after the second trimester. After the second trimester, the average weight gain per month should not be more than 2 kilograms. That is what we need to take care in all these ANC visits. Third point, we should also take down the medical history, the past medical history, and see if the female is suffering from any other diseases and so on. We should also screen the female for some diseases. Always, we have to screen the female for some diseases. First and foremost is hemoglobin screening. That is, we screen for anemia. What is the cutoff for anemia that we use in Government of India? Please, I know that again, foxy people, the faculties from Obs and Gynae, they'll be talking something else. In pediatrics, they'll be saying something else. Medicine is entirely something else. And community medicine is out of the world, entirely different answers. So for your MCQ exams, screening of anemia on a population basis, whenever the population word comes, it is the national programs. So screening of anemia on population basis, we always screen with the criteria of 1, 2, and 3. So any person who has a HB of less than 11, less than 12 or less than 13, less than 11 is in case of pregnancies, less than 12 for females and less than 13 for males. This is mg per deciliter. This is the cutoff criteria for HB in under the program. So if a female is having HB of less than 11, that is taken as anemia, and more than 11 or 11 is taken as normal. So one is regarding the hemoglobin screening. Next is point number 4. Do we do any screening or infection screening? So for screening more about infections or any disease, please note that in rural areas, the female is one we screen for hemoglobin, and we screen also for the weight. In rural areas, please note that we also screen the urine for what? For the sugars and protein. The urine for sugar and protein is screened, plus we do the malaria test. Malaria test using a rapid diagnostic kit, that is important. In cases of urban areas, we do the urine test that we have done, plus we will do the malaria test using either a rapid diagnostic kit or a slide mechanism, whatever is possible in the health facility. Plus we will also do a triple infection screening. What all infections we are going to screen for, beta? What do you want to say? It is HIV screening plus VDRL plus hepatitis B. Along with these infection screening, we are also screening the female for gestational diabetes mellitus. MCQs on gestational diabetes mellitus. So there comes your MCQ. What is GDM screening? Let us have a quick discussion about what do you mean by the GDM screening. GDM stands for gestational diabetes mellitus. Beta, please note, if a female comes to you within 12 weeks of gestation, that is during the earliest phase, that is during the registration phase. At the first visit only, during the registration visit only, we are going to do the OGTT. MCQ, what do you mean by OGTT? OGTT stands for oral glucose tolerance test. How is this OGTT done in case of GDM screening? OGTT is done using a 75 grams of anhydrous glucose, 75 grams of anhydrous glucose with a one-step procedure. With a one-step testing, there is only one step or single-step testing. So please note that is what is OGTT. So when is the first time OGTT done? Do not answer 24 to 26 weeks. Earlier, the answer used to be 24 to 26 weeks. But since last 2-3 years, I think the government of India has changed the guidelines. The GDM testing has to be done at the first registration visit. So at that time, we do the OGTT. The OGTT report could be less than 140 the female might have, or the female might have more than 140 mgdl. Are we correct on this? Mg per deciliter. So in case the female is having less than 140 per mgdl, in case the female is having less than 140 mgdl, common sense, her pregnancy will continue. The pregnancy will continue. Now, if the pregnancy will continue after a gap of some time, that is at 24 to 26 weeks, we will do a repeat OGTT. We will do a repeat oral glucose tolerance test. Please note that the repeat OGTT is done at 24 to 26 weeks. So how many times did we do OGTT in this female? We did OGTT 2 times, one before 12 weeks or at the first time of registration, and one again at 24, 26 weeks. This repeat OGTT can now be less than 140 mgdl, or it could be more than 140 milligram per deciliter. Are we okay? In case it is less than 140 mgdl, this female is called as a non-diabetic, non-GDM female. And common sense, in case the GDM, the oral glucose tolerance test report was more than 140 on either of the occasion, if it was at the first stance, of course that female will be called as a GDM female. So if at the first level the female is having more than 140, that is called as GDM. If on first time it is normal and on the second time it is higher than 140, again that is called as GDM. So MCQ comes as, what do you do to this GDM female? What will you do to the GDM female or a female who is diagnosed with gestational diabetes mellitus? Please note, to these GDM females, we are going to give MNT. MNT stands for medical nutritional therapy. Medical nutritional therapy. So this female is going to take a supervised medical nutrition therapy system for 2 weeks. So that is a trial for MNT which is given to all the females who are GDM at either the first stage or the second stage. This medical nutrition therapy, now MCQ, that after 2 weeks we are going to test again. We are going to do the oral glucose tolerance test again using that same answer, 75 grams of glucose, one step testing. So now the blood sugar could be less than 120, not 140. It could be less than 120 mg/dl, or it could be more than 120. If it is less than 120, that means this female is responding to the medical nutrition therapy. That means you just simply continue the medical nutrition therapy, and common sense, in case it is still higher than 120, that means the female is not responding to the medical nutrition therapy. So what are we going to do? We are going to put the patient on what? What do you think you're answering? You're going to put the patient on insulin. So now we put the patient on insulin. So that is what is the updated GDM guidelines for you. Please note that gestational diabetes mellitus. How do we diagnose gestational diabetes mellitus? It is diagnosed as any one positive out of the 2 tests we are doing for OGTT. So we will subject the female for OGTT 2 times. Any one positive is called as GDM. How do you rule out GDM? The ruling out of GDM is the female is both OGTTs to be negative. Negative in the sense the female should have a less than 140 mg per deciliter. So that's the way to rule out GDM, and that's the way to diagnose GDM, any one positive out of the 2 tests. So that's how the government is functioning. That please try to understand that usually it is said that how many females do you think will be gestational diabetes mellitus? It is important for us to know, because if you know that only, then only you can find out that how many females will be using insulin, because then only you should know that how many females will be having the medical nutrition therapy, because then only you will actually be able to implement this GDM screening program. So in India, it is roughly said that approximately 10 to 11% of the females may land up into GDM. Out of these 10 to 11%, 1 to 2% may require, 1 to 2% may actually require insulin therapy, because they will not be responding to the medical nutrition therapy. So these are just numbers. Maybe sometime the examiner may be interested in asking you, because that's how the program is designed, that out of all the pregnant females, we will be expecting how many? 10-11% as GDM. Out of all the GDMs, we will be expecting 1-2% as the insulin receptors. Otherwise, people will be, we think that maybe they'll be managed with the medical nutrition therapy. So that's all that you need to know about GDM screening. So now moving over to the next point number 5. The questions may be asked to you regarding the diet. See, the diet in a female is particularly important, because the diet is going to affect the weight of the female, and it is going to affect the blood pressures of the female, and consequently it is going to affect the fetus inside the female, right? So the diet should be regulated, because the weight is regulated. The average weight, we just not talked, should be 9 to 11, and there should not be any hypertension in a female. That is going to make the fetus grow well. So if we want the weight and BP to be regulated, the diet has to be regulated, and that is where the MCQs may come to you, beta. The NIN, National Institute of Nutrition, National Institute of Nutrition, which is located where? It is located in Hyderabad. Where is Hyderabad? In Telangana. So National Institute of Nutrition, which they gave the new guidelines in year 2020 for changing the recommended dietary allowance. So what I'm going to share with you is now the NIN 2020 guidelines for you. Please note that in case a female may be normal, or in case she may be a pregnant. In case we are talking of the proteins, in case we talk about the protein, in a normal female, the protein requirement is 45.7 grams a day. That's the total protein requirement for a female. In pregnancy, please note that in the first trimester, it is same. That is what you need to know, and you need to remember, it can be asked in your exam. In the first trimester, the protein requirement remains same. However, in the second trimester, it increases to female will take 9 grams. And in the third trimester, the increase is up to 22 grams extra in the third trimester. In the third trimester, it is 22 grams. Next, if you talk about the carbohydrates, in a normal female, the carbohydrate requirement is 130 grams a day, whereas in pregnancy it does increase to 175 grams a day. So the carbohydrate is increased, the proteins are definitely increased. Please take a note of it. Proteins are increased, but only in the second and the third trimester. Now comes another point about the fat. Please note that this is such a common misconception that the fat intake in normal female, it ranges from 20 to 30 grams a day. That is in a normal female. And in a pregnant female, the NIN says that the fat intake should be same 20 to 30 grams a day. It's such a common misconception that if a female gets pregnant in India, she is forced, of course, with due respect to everyone, but the culture says that the female who's pregnant in India needs to take extra fat because she's carrying a baby. Please note, more fat means more weight gain, more blood pressure, pre-eclampsia, eclampsia. So we do not want all that. Please note that the Government of India guideline says that the fat intake should remain same, and that could be a MCQ for you. Next in line, I think pretty forward. Now talking about the micronutrients, it's very easy for you. If we talk about the calcium levels in a normal female, it is 1000 milligrams calcium per day, which is required in a pregnant females. Surprisingly, it is still 1000 milligrams per day. Please note, this could be another MCQ. There is no change in the calcium levels. The calcium levels are no change. That could be another MCQ. Rest MCQs, I am very sure you already know regarding the iodine levels. If you talk about the iodine levels, what is normal iodine requirement for a normal female? It is around 160 micrograms. In case of pregnancy, it increases to 250 micrograms. Why? Because the baby is there, baby brain developing, organ developing, T3, T4 extra, you need more iodine. Common sense. Coming next to another micronutrient which you need to take care of is iron. Iron in a normal female, it is required around 29 to 30 milligrams a day. 30 milligrams a day, that is the normal iron requirement in a normal female. In pregnancy, the iron requirement definitely increases. Common sense, right? It increases to 40 milligrams a day. So please note, this could be again important, crucial MCQ for you. In a normal female, what is the level of the folic acid which is required? So I'm short of space. What I can do is I can show you a table over here. This table contains almost the same information that we have already discussed. This is the table that you need to memorize. I tried to show you in my writing that what things are important for your MCQ exam. So it's the same table. Please note that the iron intake is 40 in case of pregnancy. The calcium, and this is standing for the normal females and this is for the pregnant females. So the calcium requirement is same. The folic acid, I wanted to point over here that the folic acid in a normal female is 220 micrograms a day, whereas in pregnancy, due to common sense, it increases how many times? More than double. It is approximately 3 times, it is 570 micrograms a day. So you need to memorize that in pregnancy, the folic acid levels would increase to 570. This table, I would say, is a 5 by 5 star MCQ. I have just compiled everything together in this single table for you. This table should be useful for you at every stage. I will be talking about this table in nutrition. I will be talking about this table during lactation. I will be talking about in a normal male, female also. Of course, in pregnancy, we are right now talking about it. So what are the things which are increased during pregnancy? That's what is the take-home message. Please note that iron is definitely increased. The calcium remains same. The iodine is definitely increased. The folic acid is definitely increased. Of course, vitamin A you can say is increased. Carbohydrates are increased. Proteins you can say are increased. Very important point. The fat is missing over here. Fat is not recorded to be increased in pregnancy. The total calorie intake has been asked so many times in your exam that how much extra calories should a pregnant female be taking. Please note that during pregnancy, you have to write it in bold big letters that during pregnancy, the female needs to take 350 kilocalories extra from what she is already taking per day. So during lactation, I already told you, you can see this slide. During lactation, it is 600, 500, but many times the students get confused Please note, in pregnancy, it is more than 350 kilocals a day. So what is this Anemia Mukt Bharat program? Let us have a quick review, a few questions about this Anemia Mukt Bharat program. The Anemia Mukt Bharat program is under the Ministry of Health and Family Welfare along with other ministries. But the main ministry is Ministry of Health and Family Welfare. Next MCQ. What is this program about? Please note that this program is about 6 by 6 by 6 strategy. The program is about 6 by 6 by 6 strategies. Please note there are 6 beneficiaries. There are 6 institutions which are involved, and there are 6 interventions which we are planning to do. So what is this 6 stands for? The 6 beneficiaries. That means these are the group of population that we are benefiting to. There will be 6 institutional mechanisms or 6 institutes which are involved, and the last 6 stands for there are 6 interventions that these institutes we are going to do. In the Anemia Mukt Bharat, what is the target of the program? Beta, the target of the program is to reduce the anemia prevalence. The prevalence of anemia, whatever it was there in year 2016 as per the NFHS 4 data report, and we have to reduce it by year 2022, approximately 1/3 reduction in different age groups should be there. So that is the target of Anemia Mukt Bharat. Question number 2. Point number 2. In Anemia Mukt Bharat, who are the beneficiaries? So that could be again your 3 by 5 star MCQ. This could be your probable MCQ. Who are the beneficiaries in the Anemia Mukt Bharat? So the beneficiaries can be asked in your exam. Please note that the beneficiaries in Anemia Mukt Bharat could be 6 months to 59 months of age. Then we can have that's the first group. The second group is from 5 years till 9 years of age. The third group is from 10 years till 19 years of age. Fourth group is from 20 till 24 years of age. And the fifth group is the pregnant females. And the sixth group is the lactating females. So these are the beneficiaries under the Anemia Mukt Bharat. MCQs on this now. First MCQ. 6 months to 59 months, right? So that is 0 to 6 months are obviously not included because we are talking of Anemia Mukt Bharat. You are going to give iron, folic acid. 6 months less is exclusively breastfed, right? Common sense. There's no brainer in that. So 6 months to 59 months, that is group 1. 5 years to 9 years, all children are included. Please note all children, 6 months to 59 months, all children from 5 years to 9 years. 10 to 19 years, mark it. It's kind of a important complex MCQ, not very, very complex. 10 to 19 years, all children will be taken from who are going to school. Okay. So all school children. That means both the boys and the girls from the school. So people who go to school, they are very nice people. But from outside the school, all girls will be taken. So all girls out of school, all girls who are going to school or not going to school, but the boys only who go to school. That's what the take-home message is. So please note that who are included in the 10 to 19 year age group. In 10 to 19 year age group, all children, all girls who are going to school, not going to school, and all boys who go to school, they are included in the 10 to 19 years. Next MCQ. What is this 20 to 24 years? Where did you get these people from? How do you get these people? How do you find a female who is 20 to 24 years only? These females are taken under the Mission Parivar Vikas. We discussed in the previous module when we were discussing about the family planning and the family planning program. We discussed about MPV, that is Mission Parivar Vikas. So in the females who are registered with the Mission Parivar Vikas, the government of India, the government of India, they have taken the data from the Mission Parivar Vikas, and those females will be eligible to be having the benefit under the AMB scheme, Anemia Mukt Bharat scheme. All the pregnant females and all the lactating females are included in this. So these are the 6 beneficiaries. So that takes care of the first 6 for you. That in this we talked about the 6 beneficiaries. Next is what are the 6 institutional mechanisms you are not required to remember for your exam. These are the 6 institutes which are involved. That is, there has to be inter-ministerial coordination. There is a National Anemia Mukta AMB unit. There is a National Center of Excellence and Advanced Research or Anemia Control, that is NCEAR, on anemia. Convergence with other ministries, it definitely means inter-ministerial coordination. Strengthening supply chain anemia Mukta Bharat dashboard, it's not required for your MCQ exam. There are some 6 institute mechanisms. It's a low yield point. Now comes to your important point. What are the 6 interventions? Please note that the 6 interventions are pretty important. They have been asked in your exam. This is a 3 by 5 star MCQ topic. What are the 6 interventions? The first intervention is giving the iron folic acid supplements. The second intervention is giving the deworming tablets. Third intervention is to have a behavior change. What is the theme of the behavior change? This was the MCQ, I think 1 or 2 years back in the UPSC exam. What is the behavior change? We want to have a solid body and a smart mind. Solid body, and a smart mind. Make sure you remember this. It is solid body and a smart mind. This is the behavior change we want. Next is anemia testing. We also want anemia testing using the digital method. That is new innovative approach. Then you want iron fortified foods. Iron and folic acid, both fortified foods in all the health programs in India. It could be the midday meal scheme, it could be the Poshan scheme, it could be the Poshan Shakti Nirman scheme, whatever scheme we are talking of. We want that the government given foods, even in the Anganwadis, they should be iron folic acid fortified. And also addressing the non-nutritional causes of anemia, like malaria could be a cause of anemia, fluorosis could be a cause of anemia, hemoglobinopathies could be cause of anemia, beta thalassemia could be a cause of anemia. So these are the non-nutritional causes of anemia. They should also be addressed. But under the program, for your MCQ point of view, these are the only 2 which are required. This has already been asked, that the focus of the Anemia Mukt Bharat is to have behavior change, solid body and smart mind. So talking about the iron folic acid supplementation now. Talking about the iron folic acid supplementation in all these 6 groups. That is your first intervention. So please note, we are talking about I'll start from the lowest portion. I'm starting from the lowest portion, that is the pregnant and lactating. I have made this table for you just because of you to have a visual picture of what is happening in the Anemia Mukt Bharat. All the pregnant females and lactating females, please note MCQ, I'm starting from the lowest row, okay? All the pregnant females and the lactating females, they will be given how much iron? Please note, it is 60 milligram of elemental iron with 500 micrograms of folic acid. This tablet has to be given daily, and this is a red color tablet. Very important for you, I will write it down in somewhere in bold letters, that please note, iron folic acid supplementation is never given in first trimester. It is contraindicated in the first trimester. Iron is teratogenic. So why on earth would you give iron folic acid to a female who is just now pregnant? That will be problem for her and the baby. Iron folic acid is never given during first trimester. Only folic acid we can give. I'll talk about only folic acid separately. Iron folic acid is not given. It is started only from second trimester onwards. So please note that this is what you need to remember. It is started from second trimester onwards. It is given for how much time in pregnancy? It is given for 6 months in pregnancy, and it is given for 6 months during lactation. Total we give iron folic acid for how much time? 1 year under the Anemia Mukt Bharat. Coming to the next row, please note that the WRA females, non-pregnant, non-lactating, it is written as 20 to 49 years. It is actually 20 to 24 years, which only the program is taking right now. So 20 to 24 years, we are giving them the same tablet, 60 milligram of iron and 500 micrograms of folic acid. Please note, it is given as weekly dose. This is not daily dose. Daily dose was given to the pregnant female. Weekly dose, and the color is a red color tablet. So it's the same tablet which is given to both the pregnant females and the WRA females. What are the WRA females? That is 20 to 24 years. Next in line is the children. the adolescent boys and girls. Please note 10 to 19 years, both boys and girls from the school and only girls out of the school. They will be getting same answer, 60 milligram of elemental iron, 500 micrograms of folic acid. Same answer they are given as weekly tablets, but the tablet name you need to remember, it is a blue color tablet. Why do you think that adolescent children, they will be getting a blue color tablet and the same composition in a pregnant and WRA female is a red color tablet? Because of cultural differences. No adolescent girl in India is going to take the same tablet which a pregnant female is taking, because the color is same. How can a parent allow, or how can a girl take the same tablet which a pregnant female is taking in India? It is culturally not acceptable. So we just change the color, that is a blue tablet. So adolescent comes, we say you take a blue tablet. Pregnant comes, we say you take a red tablet. We know that within that it is the same thing. So that is what is you need to remember about the adolescent girl, the WRA female, and the pregnant lactating. Now coming to the child who is age 5 to 9 years. So below 10 years, more than 5 years, the dosage should be reduced. Iron is given in the tune of 45 milligrams and folic acid in tune of 400 micrograms, again given as weekly tablet. The color you need to remember is pink tablet. The children aged 6 months to 59 months, that is below 5 years, we are giving them 1/5 of the dose of the iron folic acid of a pregnant female. So 60 comes down to 1/4. So 60 would come down to 20 milligram and 500 would come down to 100 micrograms. So it is 20 milligram of iron, 100 micrograms of folic acid given as bi-weekly. Bi-weekly does not mean twice a week. Bi-weekly means given in 2 weeks once. And it is given as a liquid bottle with dispenser. So these are the guidelines you need to memorize for Anemia Mukt Bharat. These are 3 by 5-star MCQ topic for you. Coming over to the deworming tablets. As far as deworming is concerned, please note that the deworming tablets is given to all children whose age is 1 to 2 years. So below 2 years but more than 1 year. They will be given at the dose of 200 milligram tablet. So it's actually, we get only one tablet, so we just break that tablet into half. Half is given to the child. So half tablet the child is going to take. Half tablet is equal to 200 milligrams of what? Of albendazole. So we are talking of the biannual dose of albendazole. So under deworming, all children will be given albendazole. This albendazole is given 2 times a year. It is given on 10th of February and 10th of August. So these are the 2 days which we are observing as the National Deworming Days. National Deworming Days is on 10th of February and 10th of August. So on these 2 days, we will ensure that the child is going to get albendazole. If it's not given on these days, we can give on different days also. But these 2 are the National Deworming Days. In case the person is more than 2 years, any age, if the child or the person is age more than 2 years, then the drug that is albendazole is given at the dose of 400 milligrams tablet. So more than 2 years, it is 400 milligrams. Less than 2 years, it is 200 milligrams. So that was your point number 6. We were talking about deworming. We were talking about iron folic acid tablets which were given under the Anemia Mukt Bharat. So that was regarding the supplements, okay? Regarding the supplements to be given during pregnancy. So one, we are giving deworming single tablet, 1 tablet. We are giving iron folic acid for 1 year to the pregnant and lactating female. Alongside, do you think we should give something else, some other supplements? Yes, of course, we should give the calcium supplements. I know that the calcium recommended dietary allowance is only 1000 milligrams, but in pregnancy we give calcium at the dose of 500 milligrams. Please note that this calcium should not be given with iron folic acid supplement. Why? Because common sense, calcium will inhibit the absorption of iron. So it is always given with the space of 6 to 8 hours. Calcium taken in morning, IFA in the evening, or IFA in the morning and calcium in the evening, but not given along with iron folic acid. So these are some points you would like to remember for supplements. Point number 7. Now in this female, would you like to give some injections also? Do we give some injections? Yes, of course, we give some injections. What injection do we give? We give the tetanus toxoids. That's a wrong answer. I don't think we should give tetanus toxoid. We should give the TD vaccine. Why do you think we call it as a TD and why not a TD? Please note that the bigger D, This bigger D is what is diphtheria. It's a bigger diphtheria. So we give 25 limits of flocculation. That is the units we use. 25 LF in a bigger TD. But in pregnancy, we are giving a TD. What do you mean by a smaller D? It is a smaller dose. It is a lesser dose of the diphtheria toxoid. How much lesser? It is 2 limits of flocculation. 2 LF. That is the dose of diphtheria that we use. Limits of flocculation. So in pregnancy, we are giving injections of TD. Please note TT has been replaced by tetanus and diphtheria rather than a tetanus toxoid. Talking about this TD vaccine now, please note that all pregnancies, any pregnant female, all pregnant females should get 2 doses of tetanus diphtheria toxoid with a gap of at least 4 weeks. So they should get at least 2 doses with a gap of 4 weeks. So not TT. It has to be tetanus diphtheria 1 and then tetanus diphtheria 2 with a gap of 1 month, at least 1 month. Another MCQ which can come is that because in India the problem is too many and too frequent, right? Because there are too many and too frequent pregnancies, there could be a hypothetical chance that the female was pregnant just last year, she took a TD 2 doses, she becomes pregnant again this year, then again next year she has babies, again next year she has babies. So in that case, there could be a risk of hyperimmunization. Because there is a risk of hyperimmunization for tetanus toxoid vaccine. Therefore, it is said that any female who has taken complete TT or TD immunization within last 3 years will get only 1 dose of TD, that is the booster dose. So in case the female has taken complete TT immunization within last 3 years, she takes only 1 TD dose, that is the booster injection or the TD dose. That is what is the MCQ which can be asked about the tetanus diphtheria toxoid. So these are some of the things that you need to remember regarding ANC. Next in line coming to the intranatal care or the INC. In intranatal care, the care has to be taken for the delivery. There should be a proper safe mechanism of delivery, safe delivery. It should be conducted by a trained personnel. It should not be untrained delivery. And the delivery should be a clean delivery. It should be a clean delivery because that's the only reason that female might have a postpartum hemorrhage. We want a clean and we want a safe delivery. MCQs on this. So to have a safe delivery and clean delivery in the subsequent modules, when we talk about the RCH program, in the last module, when we talk about the RCH program, I will discuss that the government has built something called as delivery huts. They give you a safe and a clean delivery. The government has started something called as the FRUs. FRUs is first referral unit. They give you emergency care for a safe and a clean delivery, good cesarean sections, good quality of cesarean sections without any infection rate and so on. So there is a delivery huts, there is a mechanism for FRUs, and everything is controlled under the Lakshya program. What is Lakshya program for? Lakshya program is to provide good quality of labor room. So because if the labor room is good quality, good instruments are there, sanitized things are there, sterile instruments are being used, that would obviously tend to have lesser chances of infection. So the intranatal care predominantly talks about the safe delivery and the clean delivery. There is only one question on this. So what are the 5 cleans of delivery? We want a clean surface. Obviously, we want a clean surface, and beyond the clean surface, you also want that the person who's conducting delivery should have clean hands. Beyond the clean hands, you also want that once we conduct the delivery, the cord of the baby should be clean. The cord of the baby should be clean. Fourth is, because the cord should be clean, you should be clamping the cord with a clean clamp or a clean tie, and then you should have a clean cut. Okay, so we want a clean cord, clean tie, clean cut, clean hands and clean surface. These are the 5 cleans of delivery. Beta, for these 5 cleans of delivery, the government of India has started something called as disposable delivery kits. We have started something called as disposable delivery kits. In short, we call them as DDK. So what's this DDK about? What are these disposable delivery kits? So these are adhering to the 5 cleans of delivery. So in Government of India, we have these small kits. In these kits, there will be 5 cleans which are addressed to. So for clean surface, what are we going to give in a disposable delivery kit? For clean surface, we have a clean or a sterile plastic sheet. For clean hands, what do you think we are giving? Please don't answer over here that we are going to give sterilium, or we are going to give sanitizers, or we are going to give gloves. That is there in developed countries. That is in much richer country. India is a very low economically developing country. We cannot afford sanitizers for everyone. So disposable delivery kits, these fundas, disposable delivery kit should be available at all delivery points. All delivery points, even in the home-based deliveries, even in the delivery huts, even in the village delivery. So don't think that we can give any hi-fi things. So please note, for clean hands, we give a simple piece of soap, which is in fact sufficient to have a clean delivery. For clean cord, what do you think? We want that the person should be holding a cord very cleanly. You don't hold it with anything. You are given a cotton piece, a gauze piece. 1 piece of gauze will be given. Next is, what is a clean tie? How will you have a clean tie? Don't answer me clamp. Clamp is very expensive, money. So for clean tie, we have a clean thread, a piece of thread. For clean cut, don't answer scissors. For clean cut, we have to answer blade. So these are the components in a disposable delivery kit. So disposable delivery kit is such a beautiful mechanism that because the public health launched this delivery kits, disposable delivery kits at every delivery point possible in India. And that's the reason India is proud to say that in September 2015, we were able to have a neonatal tetanus elimination category. India is proud to say that because we had a clean delivery, we had a safe delivery, the neonatal tetanus elimination level was achieved, and that's what is the force of public health. So with the simple measures, that's how the things might change. So in intranatal care, these are the things you need to remember, that intranatal care, what is a clean and a safe delivery. Next is this, what is this postnatal care? Beta, in this postnatal care, that is after the delivery is over, the mother is okay, at least for the delivery point, and the baby is doing okay. So we want to have a postnatal care. Why? So please note that in a postnatal care, the main objective is for the mother I'm talking about, because this chapter we are dealing with preventive obstetrics. We are not talking about the immediate child care, right? Not immediate bacha care. We're talking of the immediate mother care. So in a postnatal care, we want that the female should be healthy. There should not be any bleed, because that is the most common reason of a female to die. In the postnatal care, we also have to ensure that the female does not develop any disease. There should not be any infections. The female should be having a hygiene, regulated, and a proper hygiene should be maintained with the female after the delivery is over. So these are prima facie the important contents of the postnatal care. So MCQ can be asked as only one, that how many postnatal care visits are there. Please note that the WHO, the World Health Organization, or the big fancy things, the WHO says that the postnatal care should be very frequent. They say that from birth till 3 days, from 3 days till the cord drops. So from the time the cord drops till 6 months, and from 6 months till 12 months. For 1 year, the postnatal visit should be there. In case of the early postnatal care, so that is within the first 3 days, it should be twice every day, twice daily for the first 3 days. That is what the WHO recommends. After 3rd day till the cord drops, usually which will be on day 5 to day 7, till the cord drops, it should be done as daily. And then it should be done as monthly. At least once a month after the cord drops till 6 months. So monthly, and then at least every 2 to 3 monthly. If you get single best answer, it is a quarterly visit which is recommended. At least 2 monthly or 3 monthly it should be there. So that is what the WHO says, but nobody is going to ask you the WHO criteria for the postnatal care visits. Please note, India in India, the postnatal care visits that we are following is the NHM, National Health Mission guidelines for the postnatal care. So what are the visits that we have in India? That is super duper easy. It is on day 1, day 3, day 7 and day 42. How many postnatal visits do you see? We see 4 visits. How many you see within the first week? We see 3 within the first week. So please note that as the baby is born, we want that the mother should be taken care as a postnatal care for 3 times at least within the first week, and then at least at the 6th week. So try to understand that what's the motive, what's the thought behind making this guideline. The thought behind making this guideline is, please note, I would like you to understand that this is not a home-based neonatal care. Many times students get confused that, sir, postnatal care, maybe the visits are 6 visits or 7 visits, Asha going to home or all that. That's a home-based neonatal care. That is different. Home-based neonatal care, that is entirely different. That's a HBNC program. I am right now talking about a postnatal care visit. So in the postnatal care visit, the thought behind making this guideline is that the early postpartum phase is very crucial for the mother because there are chances of PPH. So for first 7 days, we ensure that there are 3 postnatal visits. So first and second visit, like the first day and the third day, this can be done even by the A&M going to the home of the mother. Or the mother, if it is possible, she can come to the hospital. But 7th and 42 days should definitely be the mother coming to the hospital. Okay, so all said and done, all days, 4 days, either the mother comes to hospital or hospital goes to mother, but they all should meet for 4 days to prevent what? The main focus of PNC is to have a healthy puerperium. Healthy puerperium, and there should not be any cause of hemorrhage, any chance of hemorrhage. That is the main focus. And we also want to have a healthy child. So that is the main focus of the postnatal visits. In case the child comes as low birth weight, in normal cases, it was day 1, day 3, day 7 and day 42. In case of low birth weight, please note, you add whatever numbers you want. Day 1, day 3, day 7, day 14, day 21, day 28 and day 42. How many days you see in a low birth weight? We see 7 visits. So in a low birth weight baby, because the baby is now low birth weight, why did a baby have low birth weight? Because the mummy had some problem. So now the mummy becomes at risk. And of course, the child is at risk. So now we want to have a very close observation. We plan for 7 visits. We plan for extra 3 visits. So day 1, within 1 week, you need 3 visits. Then every week you need a visit. That's what it is, right? It's a table multiple of 7, right? I hope you got it. 7, 14, 21, 28 and 42, if you know the table of 7. So in a normal postnatal care, it is day 1, 3, 7 and 42. In a low birth weight, it is day 1, 3, 7, 14, 21, 28 and 42. So these are the dates you should remember for the postnatal visits. So now, very quickly, just to summarize for you what all are the visits. Please note that the ANC visits are, the first visit has to be within 12 weeks, 14 till 26 weeks, 28 till 34 weeks and 36 weeks till term. As far as the postnatal care visits are concerned, we want a day 1, day 3, day 7 and day 42. That is the 6 weeks. As far as the WHO new model approach is concerned for ANC. For ANC, the ANC as per the WHO, Government of India says 4 visits, the WHO says 8 visits. In the first trimester, it has to be 1 visit. Second trimester, it has to be 2 visits, and in the third trimester, it has to be 5 visits. So total is 8 visits as per the WHO care model. As far as the postnatal care visits are concerned, it is twice daily within the first 3 days, then daily till the cord drops, then it is monthly till 6 months, and then till 1 year it is 3 monthly. So these are some of the visits that you would like to remember, and that's all for your topics about the preventive obstetrics.
Hi guys, please subscribe my channels.